I'm Dr. Griffin.
And I'm Dr. Taylor.
Welcome, everyone. You are joining us for Evidence at the Bedside Board Review Edition.
Yeah, so glad to have you all here.
We're on a mission to bridge the gap between guidelines and bedside care.
We absolutely are. And for today's board review, we are really tackling a massive, just incredibly testable topic. I mean, we're talking about calcium and metabolic bone disorders.
Yeah, it's honestly a goldmine for board examiners. If you are sitting for the boards, or even if you are just, managing complex patients on the medical floors, you really cannot escape calcium homeostasis.
Oh, for sure. You're going to see it everywhere.
Right. So we are focusing heavily on diagnostic reasoning today. Because examiners, they just love to test your branching logic.
They really do, especially how you react to a PTH level in real time.
Exactly. So we are going to establish some crystal clear therapy hierarchies. And we're going to point out the common mistakes that literally catch thousands of test takers every single year.
Yeah, things like mismanaging asymptomatic primary hyperparathyroidism, or giving a potent bisphosphonate to the exact wrong patient.
Right. So let's just skip the academic stuff and jump right into the foundational branching logic of calcium regulation.
Yeah.
Because to understand the pathology, you really have to understand the normal physiological machinery.
Which makes sense. I mean, you basically have two main players controlling the board here, right? Vitamin D and parathyroid hormone, or PTH.
Yep. Their roles are very distinct. And keeping them straight is really step one for any diagnostic pathway you're going to build.
I always, I find it helps to think of calcium homeostasis as this massive banking system.
Oh, I like that.
Yeah, so the skeleton is the vault, right? That's where 99% of the calcium is stored.
Makes sense.
And the gastrointestinal tract, the gut, that's the teller window where new currency actually comes in. And then the kidney is the security guard at the door, basically deciding how much calcium is allowed to leave in the urine.
That is such a great analogy. So the primary effect of vitamin D is working at that teller window.
Exactly.
It enhances intestinal calcium absorption. It's this slow steroid hormone-mediated process that basically upregulates calcium-binding proteins in the gut lining.
Right. It takes some time. Meanwhile, the effects of PTH are primarily mediated through the security guard and the vault.
The kidney and the bone.
You got it. It regulates calcium retention in the kidney and calcium resorption from the bone. So PTH is your moment-to-moment manager when blood calcium starts to drop.
Right. And it's so essential to understand that timeline and really the feedback loops. Like the initial response to any decline in serum calcium is just this immediate rapid increase in PTH secretion from the parathyroid glands.
And what does that spike actually do? Mechanistically, it binds to receptors in the distal convoluted tubule of the kidney to decrease renal calcium excretion.
It tells the guard to lock the door.
Exactly. Then it binds to osteoblasts in the bone, which then signal the osteoclasts to start resorbing bone matrix. So it releases calcium into the blood from the vault.
Right. And crucially, and this is a big one, it induces the renal conversion of 25-hydroxyvitamin D to the active, highly potent 1,25-dihydroxyvitamin D.
Yes. And then that active vitamin D travels all the way back to the gut to increase calcium absorption. So it effectively closes the entire loop.
It is an elegant system, highly responsive. But before we even get into the pathology of that system, we really have to talk about how we actually measure the calcium in the first place.
No, this is huge.
Because the lab report itself can actively lie to you.
It is the single most common pitfall in bedside medicine, hands down.
I will push back on our daily routine here. Because we all reflexively look at the total calcium on the standard CMP, right? The comprehensive metabolic panel.
We check it every morning.
We look at that number every single morning on pre-rounds. We trend it. We react to it. But when does that number actually mislead your clinical decision-making?
Well, it misleads you almost any time the serum albumin is significantly abnormal.
Right.
Because total calcium levels, they depend heavily on the amount of calcium bound to proteins in the blood. And albumin is the primary carrier.
So it's carrying the bulk of it.
Yeah, roughly 40 to 45% of the calcium in your blood is just physically bound to albumin.
Wow.
About 10% is complexed with anions, like phosphate and citrate. And then the remaining 45 to 50% is the physiologically active free ionized calcium.
So if the albumin drops, the total calcium drops, even if the active ionized portion remains completely normal.
Exactly.
And as we know, albumin can be severely tanked by, poor nutrition, systemic inflammation, severe liver disease, nephrotic syndrome, all sorts of things.
Right. So we have all been taught to calculate the albumin adjusted or corrected calcium.
Everyone pulls out their phone for this.
Yeah. We all do. You plug it into the app, you take the measured total calcium, and you add 0.8 for every 1 gram per deciliter that the albumin is below 4. We do this to try and account for that reduction in protein-bound calcium.
But here is where residents make mistakes, and it is a classic exam setup.
Oh, yeah.
That formula is notoriously inaccurate when the serum albumin drops severely low.
Yes. Specifically, when the albumin is less than 3 grams per deciliter, the linear relationship between albumin and calcium binding just completely breaks down.
I see this constantly in the ICU. You have a critically ill patient with an albumin of like 1.8.
Yep, very common.
You use the corrected calcium formula, and it artificially inflates their calcium level. It frequently misclassifies them as normocalcemic. So that gives you this false sense of security, while the patient might actually be significantly hypocalcemic.
Exactly. So the high exam pearl here is that the most accurate assessment of calcium status when you have an abnormal albumin is an ionized calcium measurement.
Stop guessing.
Right. Do not rely on the pain formula, the corrected calcium formula in critically ill patients. It's a trap.
And it isn't just albumin that throws off the CMP, right? What about acid-base disorders? How do shifts in pH alter our interpretation?
Oh, this is a beautiful piece of physiology. So hydrogen ions and ionized calcium, they actually compete for the exact same binding sites on the albumin molecule.
Okay.
So if a patient is acidotic, say they have a severe metabolic acidosis with a pH of like 7.1, there is an excess of hydrogen ions in the blood.
Tons of protons floating around.
Right. And those protons bind to the albumin, physically displacing the calcium. This increases the free ionized calcium fraction, even though the total calcium on the CMP remains completely unchanged.
And the reverse is equally true, which is something you actually see clinically quite often.
Yes, you do.
If a patient is hyperventilating and goes into a severe respiratory alkalosis, the hydrogen ions dissociate from the albumin. That opens up the binding sites, and the ionized calcium just snaps onto the albumin.
Just vacuums it up.
Exactly. So the active calcium fraction plummets. This is why patients having a severe panic attack with hyperventilation will often complain of, perioral numbness and tingling in their fingers.
It's terrifying for them.
It is. They're experiencing acute symptomatic hypocalcemia purely from a pH shift.
That is a phenomenal clinical correlation. So the rule of thumb for your diagnostic reasoning here, you need to know exactly when to pull the trigger on an ionized calcium order.
The way do we do it?
It is indicated in the acute management of hypocalcemia or hypercalcemia during critical illness. It is absolutely mandatory when there is an inconsistency between the total serum calcium level and the patient's clinical status.
Right. If the labs don't match the patient, get the ionized.
Exactly. And it is necessary in the presence of severe acid-base disturbances. If you suspect a true disorder of calcium homeostasis, just don't guess with the formula or the ionized calcium.
Okay, so that firmly establishes our baseline for how we measure it accurately. Now let's shift to what happens when the calcium alarm bells ring from excess.
Hypercalcemia.
Right. Asymptomatic hypercalcemia is a remarkably common incidental finding on routine blood tests. And it triggers a very strict diagnostic pathway on the boards.
Extremely strict. And the very first step in that diagnostic reasoning algorithm, and I guarantee examiners will test this, is simply to repeat the measurement.
Just do it again.
Just do it again. Hypercalcemia is categorized as mild if it's less than 12 milligrams per deciliter. It's moderate between 12 and 14, and severe above 14. So if you see a mild hypercalcemia on a routine lab, your next best step is to confirm it with a repeat draw.
But why are we repeating it? I mean, are lab errors really that common?
Well, it isn't just lab error, right? Think about the conditions of the blood draw.
Okay.
Was the patient dehydrated? That hemoconcentrates everything?
Oh, sure.
Was the tourniquet left on the arm for too long by the phlebotomist? Prolonged venous stasis from a tight tourniquet can cause local fluid shifts out of the vein.
And that concentrates the proteins.
Exactly. It artificially concentrates large molecules like albumin, which in turn artificially elevates the total calcium in that specific blood sample. You never want to launch a $1 million workup based on a single, potentially spurious, mild elevation.
That makes perfect sense. But let's say we repeat it, and it's real. The calcium is 10.8. We hit the ultimate fork in the road for our diagnostic branching logic.
The big one.
Step 2 is the simultaneous measurement of serum calcium and intact PTH. This is the absolute crux of our clinical breakdown today. That simultaneous measurement categorizes the patient into either PTH-mediated hypercalcemia or non-PTH-mediated hypercalcemia?
Let's tackle the PTH-mediated side first because overwhelmingly that means primary hyperparathyroidism.
Right.
The pathophysiology here is almost always a solitary parathyroid adenoma. It's a benign tumor of one of the 4 parathyroid glands that just loses its sensitivity to calcium-negative feedback. It just pumps out PTH autonomously.
In these patients, you will see a mild hypercalcemia, and the PTH will be either frankly elevated or what we call inappropriately normal. And that phrase, inappropriately normal, is something we really need to unpack.
It is a critical concept to grasp. In a healthy endocrine system, PTH secretion should decrease abruptly, profoundly, in response to any increase in serum calcium. The parathyroid glands should just shut off.
They should go quiet.
Right. So if the serum calcium is undeniably high, a PTH that sits squarely in the upper half of the normal reference range is totally inappropriate for that level of calcium. It is diagnostic of a PTH-mediated process.
Now, if the patient have classic symptoms, the old mnemonic of stones, bones, abdominal groans, and psychiatric overtones, the decision is easy.
Very easy.
If they have kidney stones, severe osteoporosis, recurrent peptic ulcers, or profound depression linked to the hypercalcemia, they go straight to surgery to remove the adenoma.
Right, but the examiners don't usually give you the symptomatic patient. They love the asymptomatic patient.
They really do.
Yeah.
Because the asymptomatic patient requires you to memorize risk stratification tools.
Yeah.
You need to know exactly when the silent threat of primary hyperparathyroidism actually warrants surgical intervention.
Exactly.
I like to conceptualize asymptomatic primary hyperparathyroidism as a ticking clock for surgical indications.
That's a good way to look at it.
Let's create a patient. Imagine Susan, right? She's a 60-year-old postmenopausal woman. She feels perfectly fine. She runs 5Ks.
Okay, healthy Susan.
But her routine labs show a calcium of 10.9 and her PTH is elevated at 85. The exam question will ask, what is the indication for surgery? You must memorize these management algorithms because the surgical criteria are incredibly strict.
Let's walk through them logically because they all essentially represent end organ damage or high lifetime risk.
Right.
First, age. If the patient is less than 50 years old, surgery is indicated.
Why age 50?
Because the cumulative lifetime risk of developing end organ damage from decades of even mild hypercalcemia is simply too high. It is much better to just cure them now.
That makes sense. Second, we look at the absolute level of calcium. Surgery is indicated if the serum calcium level is consistently greater than 1 milligram per deciliter above the upper limit of normal.
So if the lab's upper limit is 10.5?
Right, and the patient is running at 11.6, they need surgery, even without a single symptom.
Third, we look at the security guard, the kidney. Changes in kidney function dictate surgery. Specifically, an estimated glomerular filtration rate, an eGFR, of less than 60 milliliters per minute. If the kidneys are taking a hit, you have to intervene.
And staying with the kidneys, you also need to look at what they are excreting. Surgery is indicated if the 24-hour urine calcium is greater than 250 milligrams in women or greater than 300 milligrams in men.
Because that massive calcium load going through the renal tubules is just a huge setup for nephrocalcinosis and future stone formation.
Exactly. And speaking of which, if there is clinical or imaging evidence of a silent kidney stone, that is an immediate surgical indication.
Right. And the final criteria revolve around the vault, the skeleton. You order a bone mineral density scan, a DEXA scan. If the T-score is minus 2.5 or less at any site, the lumbar spine, total hip, femoral neck, or the distal 1/3 of the radiosurgery is indicated.
Or if you see a silent vertebral compression fracture on any routine imaging, they go to the OR.
Yep. Which brings us to a massive, highly tested pitfall.
Oh, the imaging trap.
Yes. If Susan meets even one of those criteria, the clock strikes midnight and surgical management is indicated. But the vignette will describe an asymptomatic patient who clearly meets a surgical criterion, say her T-score is minus 2.7, and the multiple choice options will ask the next best step in management.
And the options will include things like referral for parathyroidectomy, order a sestamibi scan, or order a neck ultrasound.
And thousands of test takers will click the sestamibi scan. Do not pick the imaging.
Seriously, don't do it. I really want to emphasize the why here. Localized imaging, like a technetium 99-meter sestamibi scan, relies on the adenoma taking up the radioactive tracer due to its high mitochondrial content.
Right.
But that scan does not determine if surgery is indicated. It has absolutely no role in the diagnostic reasoning pathway for deciding whether a patient actually needs an operation.
It is purely a surgical GPS. That's it. Once you, the internist, have made the clinical decision that surgery is warranted based on the criteria we just listed, you refer them to the endocrine surgeon.
Let them order it.
Exactly. The surgeon will then order the sestamibi scan or the ultrasound to localize the adenoma so they know exactly where to make the incision. It tells them if they can do a minimally invasive targeted parathyroidectomy or if they need to do a full bilateral neck exploration. Never order the localizing imaging to make the decision for surgery.
That is such a vital distinction for the boards. Now, what if the patient doesn't meet any of those criteria? What if Susan is 65, her calcium is 10.7, her bones are fine, her kidneys are perfect, and her urine calcium is completely normal?
Or what if a patient meets criteria but absolutely refuses surgery? Or they're just too frail to undergo anesthesia?
Right, that happens all the time.
Then you transition to medical management. And the safety protocols here are crucial. First, you must advise them to maintain adequate hydration. They need to be drinking plenty of water to prevent kidney stones and protect their GFR.
And second, they must maintain a moderate, normal calcium intake. Sometimes patients see high blood calcium on their portal and just stop eating all dairy.
Which is a terrible idea.
It is, because severe calcium restriction can actually stimulate the parathyroid gland to work even harder, which just worsens the bone resorption.
Right. And there is a strict medication avoidance rule here, too. You must actively avoid thiazide diuretics.
Because thiazides decrease renal calcium excretion.
Exactly. They close the exit door. If you give a thiazide to a patient with primary hyperparathyroidism, their serum calcium will absolutely skyrocket.
You know, the most counterintuitive part of medical management, the part that trips up a lot of learners, is how you handle their vitamin D status.
Oh, the vitamin D paradox.
Yes, you have to cautiously correct their vitamin D deficiency. If their 25-hydroxyvitamin D is less than 20 nanograms per milliliter.
I've had residents stop me on rounds and say, wait, that seems completely backwards. Why on earth would we give vitamin D, which increases gut calcium absorption, to a patient who already has way too much calcium?
It is a brilliant physiological paradox. The reason we correct it is to prevent profound downstream complications, particularly if they eventually go to surgery.
Right.
Many patients with primary hyperparathyroidism have concurrent vitamin D deficiency. Why? Because the high PTH increases the conversion of 25-hydroxyvitamin D to the active 125 form. So it constantly depletes the storage form.
And if they are profoundly deficient and the surgeon goes in and removes that overactive parathyroid adenoma, the sudden precipitous drop in PTH halts all bone resorption instantly.
The bones just stop breaking down.
Yes. And the bones, which have been battered and broken down for years by that high PTH, suddenly switch into hyperdrive to rebuild.
They act like a sponge.
The massive sponge. They aggressively pull huge amounts of calcium and phosphorus out of the blood to remineralize the skeleton. This is known as hungry bone syndrome.
And if they are vitamin D deficient when that happens, they have no baseline mechanism to absorb enough calcium from the gut to compensate.
Their serum calcium will crash into the floor. It leads to severe, life-threatening post-operative hypocalcemia. So, preoperative or even non-operative correction of vitamin D is vital. You aim for a cautious repletion goal between 30 and 50 nanograms per milliliter, monitoring their serum calcium closely as you do it.
That explanation makes the guidelines so much easier to remember when you understand the actual mechanics behind them. Now, staying on the PTH-mediated side of the algorithm, we have to talk about the genetic trickster of the calcium world.
FHH.
Yes. The diagnosis that mimics primary hyperparathyroidism so perfectly that it routinely fools seasoned clinicians. Familial hypercalcemia.
FHH is an autosomal dominant condition, and it is almost guaranteed to show up on your exam. The pathophysiology here is fascinating. It involves an inactivating variant of the calcium-sensing receptor, the KSR gene.
Let's really drill down into how that receptor works, because it honestly unlocks the whole disease. The calcium-sensing receptor is a G-protein-coupled receptor located primarily on the surface of the parathyroid chief cells.
And also in the thick ascending limb of the loop of Henle in the kidney.
Right. In a normal individual, this receptor constantly samples the blood. When calcium levels rise, the calcium binds to the receptor, triggering an intracellular signaling cascade that basically tells the parathyroid cell, look, we have enough calcium, stop making PTH.
It is literally the thermostat for the whole system.
Exactly. But in FHH, the patient inherits a mutated receptor that requires a much higher concentration of calcium to actually trigger that stop signal.
The set point is shifted to the right.
The parathyroid gland perceives a totally normal calcium level of, say, 9.5 as too low. So it pumps out more PTH to raise the blood calcium until it finally satisfies that mutated receptor, which is usually around 10.5 or 11.
And the vignette for FHH is incredibly deceptive. It will show a patient with mild hypercalcemia that they've probably had since childhood, though it's often just discovered incidentally in adulthood.
Right.
Their PTH will be inappropriately normal or maybe mildly elevated, which exactly mirrors the lab profile of a parathyroid adenoma.
And the examiners will usually throw in a crucial piece of bait. A family history of a relative who underwent a parathyroidectomy for hypercalcemia, but the surgery just quote-unquote didn't work and their calcium remained high.
That family history of a failed parathyroidectomy is your blaring siren, because the defect is in the calcium-sensing receptor itself, which is present in all parathyroid tissue. Removing 3.5 parathyroid glands doesn't fix the underlying set point issue.
Right. The remaining tissue will just undergo hyperplasia and continue to maintain that high calcium level.
Furthermore, remember that the mutated receptor is also in the kidney. In a normal kidney, the KSR detects high blood calcium and inhibits calcium reabsorption, forcing the excess out into the urine.
But the mutated receptor in FHH fails to inhibit this reabsorption. It just continues to pull calcium back into the blood. So it leads to a paradoxical hypocalciuria, meaning extremely low calcium in the urine, despite the hypercalcemia.
So the diagnostic pearl, the absolute must-know fact to differentiate FHH from primary hyperparathyroidism, is to look at the urine. You need a 24-hour urine collection.
This is the key.
In primary hyperparathyroidism, the urine calcium is usually normal or high because the sheer filtered load of hypercalcemia eventually just overwhelms the system. But in FHH, the urine calcium is surprisingly low, typically less than 100 milligrams per 24 hours.
Even more specifically, the guidelines recommend calculating the calcium-creatinine clearance ratio. This accounts for variations in kidney function and urine volume. You measure the calcium and creatinine in both the serum and the 24-hour urine.
And what are the cutoffs?
If that ratio is less than 0.01, it is highly suggestive of FHH. If it's greater than 0.02, it points heavily toward primary hyperparathyroidism.
And the management algorithm for FHH is the ultimate safety pitfall. Do not send this patient to surgery. I really cannot stress this enough.
Never.
It is a benign condition. Because their body is physiologically used to this higher set point from birth, they do not suffer from the typical sequelae of hypercalcemia. They don't get kidney stones. They don't get osteoporosis from it.
Right. If the diagnosis is clinically ambiguous, say the clearance ratio is right on the borderline at 0.015, you confirm it with CASR genetic testing. But you keep them far away from the operating room.
Okay, so that covers the tricky PTH-mediated side. Let's look at the other fork in the road. Non-PTH-mediated hypercalcemia.
You do the simultaneous draw, the calcium is high, but the PTH is profoundly suppressed.
Usually undetectable or very low, less than 20 picograms per milliliter. The parathyroid glands are appropriately shutting off in response to an overwhelming calcium load coming from somewhere else.
The differential here is broad, but malignancy is the undisputed heavyweight.
Malignancy is the most common cause of non-PTH-mediated hypercalcemia, particularly in the inpatient setting. And unlike the mild hypercalcemia of primary hyperparathyroidism, hypercalcemia of malignancy is typically rapid in onset and severe, with calcium levels frequently soaring above 14 milligrams per deciliter.
You really have to categorize the mechanisms of how tumors cause this, because the treatments and the diagnostic tests differ. First, there is humoral hypercalcemia of malignancy, driven by tumor-produced PTH-related protein, or PTHrP.
PTHrP is a fascinating molecule. It has a very similar amino acid sequence to native PTH at the critical binding end of the molecule, so it acts like a skeleton key.
Oh, that's interesting.
Yeah, it circulates systemically, binds to the PTH receptors in the bone and kidney, and just turns on massive bone resorption and renal calcium retention. But because the rest of the molecule is structurally completely different, it does not cross-react with the standard intact PTH laboratory assay.
Ah, so your native PTH reads as low while the calcium skyrockets.
Exactly. You classically see PTHrP production in squamous cell cancers, like squamous cell carcinoma of the lung, head, and neck, as well as renal cell carcinomas and some breast cancers. You diagnose it by ordering a specific assay for PTHrP.
The second mechanism is locally mediated osteolysis. This is literally tumors invading and destroying the bone matrix directly.
Right. The malignant cells release local cytokines like interleukin-1, interleukin-6, and TNF-alpha, and these aggressively stimulate osteoclast differentiation and activation.
The osteoclasts just chew up the bone, releasing massive amounts of calcium. This is the classic mechanism for multiple myeloma and breast cancer with extensive skeletal metastases.
And the third malignancy mechanism is the unregulated extrarenal production of 125 dihydroxyvitamin D. We primarily see this in certain lymphomas, particularly Hodgkin and some non-Hodgkin lymphomas.
The tumor macrophages basically possess their own 1-alpha hydroxylase enzyme, so they convert precursor vitamin D to the active form, driving relentless intestinal calcium absorption.
That mechanism actually bridges us perfectly to another major, highly tested cause of non-PTH hypercalcemia, granulomatous disease. This is a vital diagnostic connection to make.
Yes, conditions like sarcoidosis, tuberculosis, and disseminated fungal infections involve the formation of granulomas. The macrophages inside these granulomas act exactly like those lymphoma cells.
They contain an unregulated 1-alpha hydroxylase enzyme.
Right. It converts 25-hydroxyvitamin D into the active form without any regard for negative feedback inhibition.
Because normal kidneys shut down that conversion when calcium levels rise, granulomas do not care. They just keep pumping it out.
So the patient presents with hypercalcemia, a suppressed PTH, a normal 25-hydroxyvitamin D level, but a sky-high 125-dihydroxyvitamin D level.
And the clinical pearl for this vitamin D-dependent hypercalcemia, whether from granulomatous disease or from a patient simply taking massive toxic overdoses of over-the-counter vitamin D supplements, is the specific treatment. It uniquely involves glucocorticoids.
Glucocorticoids like prednisone are highly effective here. They work through multiple mechanisms. They directly downregulate the activity of that unregulated 1-alpha hydroxylase enzyme in the macrophages, and they also directly inhibit intestinal calcium absorption.
It is a highly specific, very testable therapy choice that really gets to the root of the pathophysiology.
Let's expand on therapy. We've talked about the specific treatment for granulomas, but let's talk about the universal therapy hierarchy for severe hypercalcemia across the board. Say you have a patient rolling into the emergency department. Their calcium is 16 milligrams per deciliter. They are lethargic, confused, and profoundly weak. What is the absolute first order we are putting into the system?
The first line, undeniable therapy, is aggressive intravenous hydration with 0.9% normal saline.
Always saline first.
Always. You have to understand the renal physiology of severe hypercalcemia to know why this is step one.
Let's break that down. Why is this patient so volume depleted in the first place?
Because severe hypercalcemia induces a reversible nephrogenic diabetes insipidus-like state. High levels of calcium in the renal medulla actually interfere with the action of antidiuretic hormone, ADH.
Okay.
The calcium physically blocks the insertion of aquaporin water channels in the collecting duct. So the kidney just loses its ability to concentrate urine. The patient begins pouring out liters of dilute urine, causing massive polyuria and profound systemic dehydration.
Furthermore, that volume depletion triggers a vicious cycle.
Mm.
Because the patient is dry, their GFR drops. The proximal tubule frantically tries to reabsorb sodium to restore intravascular volume. And because calcium is passively reabsorbed alongside sodium in the proximal tubule, the kidney reabsorbs even more calcium.
Which just worsens the hypercalcemia.
Exactly.
So your first step is to break that cycle. You give aggressive saline hydration, often at rates of 200 to 300 milliliters per hour, depending on cardiovascular status.
That's a lot of fluid.
It is. It restores the intravascular volume, improves the GFR, and shuts down that proximal tubule avidity for sodium and calcium. By flushing the system with sodium chloride, you competitively induce a calciuresis. You force the calcium out in the urine.
And here comes a major historical trap that examiners still love to test. The vignette will describe you giving those first 2 liters of normal saline, and then they will ask for the next best step. The options will include initiate a loop diuretic like furosemide.
Yeah, for decades, medical students were taught to aggressively hydrate and then heavily diurese with the loop diuretic to quote-unquote wash the calcium out. But you must explicitly know this modern safety protocol. Routine use of loop diuretics is not recommended in the initial management of hypercalcemia.
The logic makes sense when you think about it. Loop diuretics act on the thick ascending limb of the Luke of Henle. They block the sodium-potassium chloride cotransporter, which abolishes the positive luminal potential, thereby preventing the paracellular reabsorption of calcium.
So yes, they do cause calcium to be excreted.
But they also cause massive diuresis.
And that's the danger. Giving a potent loop diuretic to a patient who is already profoundly volume depleted from their hypercalcemia-induced diabetes insipidus will drastically worsen their dehydration.
It will precipitate acute kidney injury.
It can cause cardiovascular collapse and ultimately decrease GFR, thereby worsening the hypercalcemia. You only reach for a loop diuretic if the patient has specific, compelling indications. For example, if they have concurrent oliguric renal failure, or if they develop clinical volume overload like pulmonary edema from the massive amounts of saline you just pumped into them. Otherwise, stick to aggressive saline.
For long-term management of malignant hypercalcemia, or if the hypercalcemia is refractory to hydration, you move down the hierarchy to anti-resorptive agents.
Right. Intravenous bisphosphonates like zoledronate or pamidronate are the mainstays here. They bind to the bone matrix and undergo endocytosis by osteoclasts, causing osteoclast apoptosis and halting the release of calcium.
But bisphosphonates take 2 to 3 days to reach maximum effect. If you need something faster, say for a critically ill patient, you can use subcutaneous calcitonin.
Calcitonin works rapidly, within hours, to inhibit osteoclast activity and increase renal calcium excretion. However, calcitonin is subject to rapid tachyphylaxis.
Oh.
Yeah, downregulation of the calcitonin receptors occurs within 48 to 72 hours, so its efficacy just vanishes quickly. It is strictly a bridge therapy while you wait for the bisphosphonates to kick in. And remember, if the patient has severe renal impairment, bisphosphonates are contraindicated, and you would use subcutaneous denosumab instead.
Okay, that is a really comprehensive tour of calcium excess. Let's flip the clinical scenario. What happens when the parathyroid glands get damaged or suppressed, or the gut stops absorbing, and the serum calcium precipitously drops? Why is hypocalcemia considered a silent, acute emergency, and what is the hidden electrolyte we always forget to check?
Severe hypercalcemia is terrifying for clinicians because of the stark safety pitfalls associated with its presentation. When the serum calcium drops significantly, typically below 7.5 milligrams per deciliter, the neuromuscular irritability skyrockets.
But why does it cause irritability? You would think less calcium means less muscle contraction.
It's all about membrane stability. Extracellular calcium ions stabilize the voltage-gated sodium channels on nerve membranes. When extracellular calcium drops, the threshold for sodium channel depolarization drops with it. The nerves become incredibly twitchy and fire action potentials with minimal provocation.
That's why you see the classic physical exam findings we learned in medical school. Schroestek's sign, which is facial nerve hyperirritability. You tap the cheek over the facial nerve just anterior to the earlobe, and the facial muscles twitch.
Or Trousseau sign, which is carpopedal spasm. You inflate a blood pressure cuff above systolic pressure for 3 minutes to induce local ischemia, and the wrist and fingers spasm into flexion.
But the critical, must-know fact for the boards is that severe hypocalcemia can cause devastating consequences entirely without any of those classic warning signs.
Yes. A patient might not have paresthesias or muscle cramping at all. Instead, they can present with sudden laryngospasm cutting off their airway, generalized tonic-clonic seizures, severe reversible heart failure from myocardial dysfunction, or QT interval prolongation.
That QT prolongation is the killer. It predisposes the patient to torsades de pointe and sudden cardiac death. A patient can go from seemingly asymptomatic to a lethal arrhythmia in a heartbeat.
Because of that catastrophic risk, your diagnostic reasoning must be airtight and immediate. When you confirm hypocalcemia, you order a mandatory comprehensive lab panel.
You do not just trend the calcium.
No. The panel must include simultaneous measurement of serum calcium, phosphorus creatinine, intact PTH, and magnesium.
I cannot emphasize the magnesium piece enough. I will never forget a patient crashing with hypocalcemia during my residency. We were pushing ampules of IV calcium gluconate, and the serum numbers just would not budge.
Oh, wow.
The patient was twitching, the EKG looked terrible. I was completely baffled until my attending calmly walked in and asked, "What is the magnesium level?" It was 0.8. I had no idea magnesium could basically turn off the entire parathyroid regulatory system.
It is an incredibly high-yield concept. Why is magnesium on that mandatory list? Because hypomagnesemia causes a profound, reversible, functional hypoparathyroidism.
Think of magnesium as the electricity powering the parathyroid factory. It doesn't matter how much raw material you have or how high the demand is. If the power is cut because of low magnesium, the factory cannot manufacture or release the product, the PTH.
Mechanistically, intracellular magnesium is required for the activation of adenylate cyclase, the enzyme that generates CAM-MP, which is necessary for the exocytosis of PTH granules from the chief cells. Furthermore, severe hypomagnesemia causes peripheral skeletal resistance to whatever small amount of PTH is actually released.
And hypomagnesemia is rampant on the medical wards. You see it in patients with severe alcohol use disorder, generalized malnutrition, chronic diarrhea, or those on long-term loop diuretics.
It is also famously caused by chronic use of proton pump inhibitors, which impair intestinal magnesium absorption.
The clinical presentation will look exactly like permanent primary hypoparathyroidism.
Yeah.
You'll see a low serum calcium and a low or inappropriately normal PTH.
The board trap is that if you don't check the magnesium, you might label them with a permanent disease. And more acutely, as you experienced, if you don't replace the magnesium, no amount of exogenous calcium supplementation will fix the hypocalcemia.
Because the kidneys will just excrete it without PTH there to reclaim it.
Exactly. You must correct the magnesium first. Once the electricity is back on, the parathyroid gland wakes up, pumps out PTH, and fixes the calcium itself.
Now, speaking of true permanent hypoparathyroidism, the most common cause is iatrogenic specifically. Inadvertent injury, devascularization, or removal of the parathyroid glands during anterior neck surgery, like a total thyroidectomy for thyroid cancer.
But the examiners also love medication-induced hypocalcemia traps. We, as internists, cause a lot of iatrogenic hypocalcemia without ever touching a scalpel.
We certainly do, most notably when we prescribe potent anti-resorptive drugs. Intravenous bisphosphonates like zoledronate or the NK inhibitor denosumab are designed to aggressively shut down osteoclast activity. This rapidly halts the physiologic efflux of calcium from the skeleton into the blood.
In a healthy patient, the parathyroid gland senses the slight dip in calcium, ramps up PTH, stimulates the kidney to hold on to calcium, and ramps up vitamin D conversion to pull more from the gut. The system reaches a new equilibrium.
But what if that compensatory mechanism is broken? If you give one of these potent drugs to a patient who has an underlying, unrecognized, severe vitamin D deficiency, their gut cannot absorb enough calcium to compensate for the sudden shutdown of the skeletal supply.
Their serum calcium will plummet and stay down for a protracted, dangerous period.
This is why patients develop severe hypocalcemia after their first dose of Prolia or denosumab. The mandatory safety step, and the guaranteed exam answer, is that you must always assess a baseline 25-hydroxy vitamin D level and actively correct any deficiency before you ever initiate a potent anti-resorptive drug.
Excellent point. Now, let's look at the chronic management of these patients. Let's assume you have a patient with confirmed chronic hypoparathyroidism, say they are 5 years post-thyroidectomy. The management algorithm here requires a very delicate physiological tightrope walk. Your therapy options are high-dose vitamin D supplementation, massive amounts of oral calcium carbonate or calcium citrate, and often active calcitriol because they lack the PTH to convert precursor vitamin D. But what is the specific target goal of this therapy?
This is a highly nuanced point that consistently separates the experts from the novices on the exam. The goal of therapy for chronic hypoparathyroidism is explicitly not to achieve a perfectly normal serum calcium level.
It's not.
The goal is to keep the serum calcium at, or just barely below, the lower limit of the normal reference range, typically around 8.0 to 8.5 milligrams per deciliter.
That requires explanation. If the patient feels better with fewer paresthesias at a normal level of 9.5, why are we artificially keeping them low?
It all comes back to the kidney. In a normal individual, PTH is the crucial signal that stimulates the distal tubule of the kidneys to reabsorb calcium from the urine filtrate back into the bloodstream. In a patient with hypoparathyroidism, you have no PTH. Therefore, you have absolutely zero active renal calcium reclamation.
So, if you pump the patient full of oral calcium pills and calcitriol to forcibly normalize their blood levels, what happens to all that extra calcium as it passes through the glomerulus?
It dumps straight out into the urine.
Because the door is wide open without PTH there to close it.
This leads to massive hypercalciuria. The urine becomes supersaturated with calcium, leading to precipitation, nephrocalcinosis, kidney stones, and eventually chronic renal failure. You keep the blood calcium slightly low to limit the filtered load, thereby protecting the kidneys from catastrophic calcium overload. You treat to the point of eliminating symptoms, not to normalize the number.
That is a phenomenal breakdown. And to help manage that hypercalciuria, we utilize a very specific pharmacological hack. We use thiazide diuretics.
Wait, let's clarify this for the listener because it can sound contradictory. Earlier in the hypercalcemia section, we said you must strictly avoid thiazides because they retain calcium and worsen hypercalcemia. Here, in hypoparathyroidism, you're telling me we intentionally use thiazides.
Yes, and it is a brilliant use of renal physiology. Thiazide diuretics block the sodium chloride symporter in the distal convoluted tubule. This causes mild volume depletion, which leads to compensatory increased sodium reabsorption in the proximal tubule.
Okay, I follow.
And as we discussed earlier, calcium follows sodium paracellularly in the proximal tubule. So by giving a thiazide, you indirectly increase proximal calcium reabsorption, pulling it out of the urine and back into the blood.
It decreases urine calcium excretion, keeping the calcium in the blood and out of the kidney tubules. It allows you to maintain a safe serum calcium level using lower doses of oral calcium supplements, drastically reducing the risk of kidney stones.
Exactly. It is a cornerstone of managing chronic hypoparathyroidism. Now, chronic calcium imbalances inevitably take their toll on the vault. The skeletal structure suffers. This leads us seamlessly into metabolic bone disease, specifically differentiating and managing the structural fallout. Let's start with the most common, osteoporosis.
The diagnostic reasoning for osteoporosis on the boards doesn't always start with a bone density scan. It often starts with a clinical event, defining a fragility fracture. The definition is rigid. It is a fracture occurring spontaneously or from trauma equivalent to a fall from a standing height or less.
If a healthy 30-year-old falls off a ladder and breaks their hip, that is high-energy trauma. But if a 65-year-old woman trips on a rug in her living room, falls to the floor and fractures her femoral neck, that is a fragility fracture.
That clinical event definitively diagnoses osteoporosis, regardless of what her DEXA scan says. Her bones have failed mechanically under normal physiological loads.
But watch out for the board trap regarding fracture locations. The vignette will describe an older patient who falls from standing height and they fracture their skull, their cervical spine, their hand, or their ankle. And the question will imply you should start osteoporosis treatment.
Those do not count. Fractures of the skull, cervical spine, hands, ankles, and feet are not considered fragility fractures. The biomechanics, the cortical to trabecular bone ratios, and the trauma mechanisms for those areas are different.
Right.
They do not routinely trigger the osteoporosis diagnostic pathways. You are looking for the classic major osteoporotic fracture sites. The hip, the vertebral bodies of the spine, the proximal humerus, and the distal forearm or radius, the classic collis fracture.
If they haven't suffered a fracture, then we rely on the DEXA scan dual energy absorptiometry. We look at the T-score, which compares the patient's bone density to a healthy, young 30-year-old reference population. A T-score threshold of -2.5 or less at the spine, hip, or femoral neck is diagnostic of osteoporosis in postmenopausal women and in men aged 50 and older.
But diagnosing it is only half the battle. You have to look at risk stratification tools because secondary causes of osteoporosis are highly testable and they change your management timeline.
Oh, they certainly do.
The massive, unavoidable risk factor you must commit to memory is glucocorticoid use. Chronic systemic steroids are absolute bone killers. They directly inhibit osteoblast function, they induce osteoblast apoptosis, and they decrease intestinal calcium absorption. They cause significant rapid bone loss, predominantly in the trabecular bone of the spine.
The high-yield pearl here involves a very specific timeline and dosage threshold. Any patient anticipated to be on greater than or equal to 2.5 milligrams per day of a glucocorticoid like prednisone for more than 3 months needs an immediate fracture risk assessment.
I see this mistake frequently. A patient is started on high-dose prednisone for new-onset polymyalgia rheumatica, and the physician thinks, I'll check a DEXA scan at their annual physical next year to see how their bones are handling it.
You cannot wait a year.
The most rapid phase of glucocorticoid-induced bone loss occurs in the first 3 to 6 months of therapy. You assess their risk using clinical tools like the FRAX score, and you often initiate prophylactic anti-resorptive therapy at the exact same time you write the steroid prescription.
That is the standard of care. So let's walk through the therapy hierarchy for osteoporosis, because the guidelines are rigid and heavily tested.
First-line therapy for primary osteoporosis in patients with a high fracture risk is an anti-resorptive medication, specifically a bisphosphonate. Oral options include alendronate or risodronate, usually taken weekly or monthly. If oral tolerance is an issue due to severe esophageal reflux or inability to sit upright, you use an intravenous bisphosphonate like zoledronate, given once a year.
We discussed how they work earlier. They embed in the bone matrix, get eaten by osteoclasts, and induce apoptosis by inhibiting the farnesyl pyrophosphate synthase enzyme. But you cannot prescribe them blindly.
The major safety pitfall and an absolute contraindication for bisphosphonates is reduced kidney function. Because these drugs are cleared almost entirely by the kidneys, administering them to a patient with renal impairment leads to massive drug accumulation and potential nephrotoxicity.
The hard cutoff you must memorize is a creatinine clearance of 35 milliliters per minute. If the CRCL is less than 2.5, bisphosphonates are absolutely contraindicated.
The vignette will give you an 82-year-old frail woman with a recent hip fracture. She desperately needs osteoporosis treatment, but her lab work shows a creatinine clearance of 28. The trick answer choice will be initiate oral alendronate. Do not fall for it.
So what do you do for that patient? If they have severe chronic kidney disease or if they simply cannot tolerate bisphosphonates, you move to the second-line alternative, denosumab.
Denosumab is a targeted biologic therapy. It is a monoclonal antibody that acts as a decoy receptor. It binds directly to ANCO receptor activator of nuclear factor kappa B ligand. In normal physiology, osteoblasts release NKL, which binds to osteoclast precursors and signals them to mature and start destroying bone.
By neutralizing ANKL, denosumab powerfully and rapidly halts osteoclast activation.
It is given as a subcutaneous injection every 6 months, and importantly, it is not cleared by the kidneys, so it does not have the same strict renal contraindications. But denosumab comes with its own massive, highly dangerous boar trap.
The denosumab trap is entirely about what happens when you stop the drug. The bone-protecting effects of denosumab are profound, but they are not sustained in the bone matrix like a bisphosphonate.
Right, the moment the antibody clears the system, there is a massive backlog of uninhibited osteoclast precursors ready to mature.
If a patient misses a dose by even a month or two, or if you intentionally decide to stop the therapy, you get a massive, rapid rebound of osteoclast activity.
The osteoclasts aggressively attack the skeleton. The patient will suffer rapid, catastrophic bone loss, frequently resulting in multiple spontaneous vertebral compression fractures within months of stopping the drug.
Therefore, the strict management algorithm dictates that if you stop denosumab for any reason, you must bridge the patient with a bisphosphonate. Typically, you administer an intravenous infusion of zoledronate exactly 6 months after their last denosumab injection. This locks in the bone density gains they achieved and prevents the rebound hyperresorption. You never just stop denosumab and walk away.
Let's also touch on drug holidays, because that concept only applies to bisphosphonates. Once you start a bisphosphonate, the patient isn't necessarily locked into it for life. Because the drug embeds into the bone matrix and stays there for years, continuing to suppress remodeling, you have to balance efficacy against long-term risks.
Those risks include atypical femur fractures, subtrochanteric fractures that occur with minimal trauma due to the bone becoming overly brittle and unable to repair microdamage, and osteonecrosis of the jaw. Both are rare, but the risk increases exponentially with prolonged duration of therapy, typically beyond 5 years.
So if a patient's fracture risk has been successfully lowered after a period of treatment, you consider a drug holiday. The standard recommendation is to reassess after 3 years of intravenous zoledronate or after 5 years of oral bisphosphonates. If their bone density is stable and they haven't fractured, you stop the drug and monitor them.
Those are the core mechanics for osteoporosis. But what about osteomalacia? The boards will absolutely test your ability to distinguish between the two because on the surface, they look similar.
I'm so glad you brought that up because I want to clarify how these are presented. Both osteoporosis and osteomalacia present with an older patient complaining of diffuse bone pain. They both present with low bone mass on a DEXA scan, and they both result in fractures. How does a test vignette differentiate osteomalacia from run-of-the-mill osteoporosis?
It all comes down to the underlying pathophysiology and the resulting lab work. Osteoporosis is a quantitative defect. You have perfectly normal, healthy, fully mineralized bone tissue. You just don't have enough of it. The architectural struts are too thin.
Okay.
Because the tissue itself is normal. The basic lab work serum, calcium, phosphorus, alkaline phosphatase, and PTH will all be completely normal in primary osteoporosis.
Osteomalacia, on the other hand, is a qualitative defect. It is literally a mineralization defect. The most common cause in adults is severe prolonged chronic vitamin D deficiency.
The osteoblasts are dutifully laying down the collagen protein matrix, the osteoid, but because there is inadequate calcium and phosphorus available due to the lack of vitamin D, that matrix never calcifies. You end up with soft, unmineralized, structurally weak bone.
So the must-know facts for an osteomalacia vignette are the distinct lab abnormalities. You will see an elevated alkaline phosphatase. Why? because the osteoblasts are frantically working overtime, trying to mineralize the unmineralized osteoid seams, and alkaline phosphatase is a byproduct of osteoblast activity.
You will also see low normal serum calcium and phosphorus, reflecting the severe malabsorption. You will see a compensatory elevated secondary PTH as the body tries to maintain blood calcium.
And crucially, you will see an extremely low 25-hydroxyvitamin D level, almost always less than 10 nanograms per milliliter. The combination of an elevated alkaline phosphatase, bone pain, and severe vitamin D deficiency is your massive red flag for osteomalacia.
Exactly. And the treatment is completely different. You do not give bisphosphonates for osteomalacia. Bisphosphonates inhibit bone resorption. They don't fix mineralization.
Treating osteomalacia requires giving massive replenishment doses of vitamin D, often 50,000 units weekly for several months, along with adequate calcium to provide the raw substrate needed to finally mineralize that waiting bone matrix.
We've covered systemic bone loss with osteoporosis and systemic mineralization defects with osteomalacia. But what about focal chaotic bone remodeling? What if just one or two bones in the body are behaving abnormally? This brings us to Paget disease of bone.
Paget disease is a fascinating localized disorder of uncoupled hyperactive bone remodeling. It is essentially an anarchic construction site.
The initial insult is driven by massive multinucleated rogue osteoclasts that rapidly and aggressively resorb local areas of bone. In response, osteoblasts frantically rush in to fill the void, but they do it too quickly.
They lay down disorganized, chaotic woven bone instead of strong, structured lamellar bone. The resulting bone is enlarged, highly vascular, but structurally weak and prone to deformity and fracture.
The diagnostic reasoning here relies on recognizing a very specific clinical picture. The classic exam vignette is an asymptomatic older patient, usually of European descent, whose routine comprehensive metabolic panel shows an isolated, significantly elevated alkaline phosphatase level.
That isolated elevation is key. Their serum calcium and phosphorus are totally normal. And to prove the alkylvos is coming from bone and not the liver, the vignette will usually state that their GGT gamma-glutamyl transferase and other liver enzymes are completely normal.
Alternatively, they might present with clinical symptoms of the bone expansion. They might complain of bone pain over a specific long bone, or an incidental radiograph might show thickened cortical bone and coarsened trabecular markings.
The classic historical presentations are the patient who complains their hat doesn't sit anymore because their skull has enlarged, or you see progressive bowing of the tibia causing a change in their gait.
When you suspect Paget disease based on that high alk-phos or the clinical exam, the next best step in management is highly testable. You do not just order a radiograph of the symptomatic bone. The next best step is a whole body radionuclide bone scan.
Why a whole body scan?
Because you need to identify all the involved skeletal sites. The disease can be monostotic, affecting just one bone, or polyostotic, affecting multiple sites like the pelvis, spine, skull, and femur.
The radionuclide scan detects areas of active high bone turnover. Knowing the full extent of the disease dictates your monitoring strategy and helps predict future complications. For example, extensive polyostotic disease acts as a massive arteriovenous shunt due to the hypervascularity of the pagetic bone, which can rarely lead to high-output heart failure.
Once you've mapped the disease with the bone scan, you have to decide on the management algorithm. And crucially, not every patient with Paget disease requires treatment. If they have an asymptomatic lesion in a non-weight-bearing bone, you might just observe.
The indications for treatment include bone pain directly related to the pagetic lesions. It includes a high risk for fracture or deformity, especially if the disease involves weight-bearing bones like the femur or tibia, and it includes the prevention or treatment of nerve compression syndromes.
A classic example of nerve compression is a patient developing hearing loss. The pagetic expansion of the temporal bone at the skull base physically compresses the vestibulocochlear nerve or alters the mechanics of the ossicles in the middle ear. If you see that, you treat.
If they meet those clinical indications, the therapy hierarchy is incredibly straightforward. First-line therapy is intravenous zoledronate.
But the dosing is different here than in osteoporosis.
It is. You use a single 5 milligram dose of 5E zoledronate. That single potent infusion is so profoundly effective at resetting the chaotic osteoclast activity that it can normalize the alkaline phosphatase and relieve symptoms for years, often up to 5 years or more from just one dose. It is a remarkably effective targeted therapy.
And you monitor their clinical response by checking that serum alkaline phosphatase annually. If the OCFOS remains normal, the disease is in remission. If it starts to climb back up above the normal range years later, indicating a relapse of rogue osteoclast activity, you consider retreating them. It is a very clean, testable algorithm.
All right, we have covered an immense amount of complex physiology and clinical reasoning today. Let's lock this in with our summary, the rapid-fire review of the top 10 high-yield takeaways that listeners should memorize for exam day.
Number 1. When the albumin drops severely below 3, the corrected calcium formula fails. Rely on the ionized calcium to accurately assess their status.
Number 2. For asymptomatic primary hyperparathyroidism, memorize the rigid surgery criteria. Age less than 50, calcium consistently 1 milligram over normal, eGFR less than 60, specific high urine calcium cutoffs, and a T-score of minus 2.5 or worse.
Number 3. Beware the FHH urine trick. If you see mild hypercalcemia, an inappropriately normal PTH, but a 24-hour urine calcium less than 100 milligrams and a clearance ratio less than 0.01, think familial hypocalciuric hypercalcemia. Do not operate on these patients.
Number 4. In the therapy hierarchy for severe hypercalcemia, aggressive normal saline hydration is always step 1 to combat the nephrogenic diabetes insipidus state. Routine loop diuretics are a historical trap unless the patient is definitively volume overloaded.
Number 5. Severe hypocalcemia requires simultaneous mandatory measurement of calcium, phosphorus, creatinine, intact PTH, and magnesium.
Number 6. Hypomagnesemia shuts down the parathyroid factory. It causes reversible functional parathyroid hypofunction. You absolutely must correct the magnesium before you can definitively fix the calcium.
Number 7. In the chronic management of hypoparathyroidism, you intentionally use thiazide diuretics. They decrease urine calcium excretion, protecting the kidneys from nephrocalcinosis while you supplement with oral calcium.
Number 8. Glucocorticoids are rapid bone killers. Anyone starting a dose greater than 2.5 milligrams per day for an anticipated duration of more than 3 months needs an immediate fracture risk assessment. Do not wait.
Number 9. Memorize the creatinine clearance rule for bisphosphonates. If the CRCL is strictly less than 35, bisphosphonates are absolutely contraindicated due to the risk of accumulation.
And number 10. Master differentiating metabolic bone disease. An elevated alkaline phosphatase with low calcium and extremely low vitamin D means osteomalacia, a mineralization defect. An isolated high alkaline phosphatase with perfectly normal calcium in an older adult points straight to Paget disease, which you treat with a potent single dose of IV zoledronate.
Excellent rapid fire. To wrap up today's clinical breakdown, I want to leave you with a final, slightly provocative clinical reflection. Throughout this entire review, we've talked about relatively crude macroscopic markers, serum calcium levels, intact PTH assays, and alkaline phosphatase. But there is a glaring paradox in modern bone medicine.
What is the paradox?
It involves bone turnover markers. We have specific biochemical assays like serum CTX for bone resorption and P1NP for bone formation. These peptides are released directly into the blood during active skeletal remodeling. They are highly utilized in clinical trials. They are how pharmaceutical companies prove exactly how fast their new drugs work. Yet, they remain frustratingly undefined, unstandardized, and heavily underutilized for our daily bedside practice.
It is a massive gap in our current clinical capability. Right now, we start a patient on a bisphosphonate and wait 2 entire years for a repeat DEXA scan just to see if the therapy is actually working. Challenge yourself to consider how the future of personalized medicine might evolve here. Imagine a future where we routinely measure an individual patient's real-time bone remodeling rates using these precise turnover markers just weeks after starting therapy. It would shift osteoporosis care entirely, moving us away from a game of statistical averages based on slow macroscopic imaging toward exact, highly responsive, patient-specific pharmacology. That is the true frontier we are marching toward.
It is going to change the way we practice endocrinology and internal medicine entirely.
Thank you for joining us. If you found these high-yield reviews helpful for your ABIM prep or clinical practice, please subscribe and share this with your team. We're on a mission to bridge the gap between guidelines and bedside care. Keep studying hard, trust your branching logic, and we will see you next time.